kind of the next decision in this process is to try to understand what the optimal therapy would be. And if you look at the various guidelines that are available to us, there are many options. And it's actually a little controversial as to exactly what the best option is. And I think that the fact that paclitaxel and carboplatin are still the backbone of the therapy that we use, even today, now more than 20 years since it was introduced into ovarian cancer in the frontline setting, speaks to the fact that this is still a decent backbone. So most of what we have done in the last 2 decades in the research side of things is try to figure out ways to either add to this regimen or to substitute it for other chemotherapy agents on top of platinum, or to figure out different schedules. And all of those are relevant, and all of them make sense. So one of the first things I would say that kind of a common standard of care would be to use paclitaxel and carboplatin with the intent of administering 6 cycles of treatment. And the paclitaxel would be administered on a 3-weekly basis. So both drugs would be given once every 21 days. And this would be considered, a definite standard and one we have used over and over again. With a patient who's had an R0 resection, we investigated almost the same amount of time ago, 2 decades, whether or not receiving chemotherapy directly into the abdominal cavity would be a better way to deliver the therapy. And we did a series of experiments over the last 2 decades to try to isolate exactly what the role was. And unfortunately, it's very difficult to say that we know for sure what the role should be in a patient such as this as to whether or not they should receive intraperitoneal therapy. I think many people feel that intraperitoneal therapy is the optimal way to deliver drugs like platinum and paclitaxel because it delivers relatively high doses of the drug directly to the tumor, and when there's low volume of tumor in the abdominal cavity, it would make sense. So there may be this pharmacological advantage to getting the fluid directly into the abdominal cavity, the chemotherapy directly into the abdominal cavity. The trials that we have done have been hard to interpret because they've suffered from having different infusion schedules for the drugs that have been administered. They've had different control arms, and they've had somewhat different findings, although all of the trials that have been done essentially have shown that there's a very strong progression-free survival advantage, and in some, at least the strong signal that there may be a survival advantage. But there are caveats in all of these trials, and it's been difficult for us to settle on a clean recommendation that all patients with a complete resection should have intraperitoneal therapy. There's definitely more side effects associated with that. It's difficult for patients to receive all their treatment intraperitoneally, and that seems to be important as far as the benefit that patients received while getting an IP. So a lot of these caveats do make it difficult to understand what the optimal, or whether or not intraperitoneal therapy should be considered. To add more confusion, we have now experienced some data looking at fractionating the paclitaxel in a large study that was done by the Japanese, where all they did was to change the weekly infusion, or change the paclitaxel from Q3 weeks to every week and then using the carboplatin every 3 weeks. That this was a very effective way, which produced a progression-free and an overall survival in their patient population. And we've kind of repeated that in a European or Western population with less dramatic results. One of the strategies was to also fractionate the carboplatin. So you got weekly carboplatin and weekly paclitaxel. And that didn't really seem to show this degree of benefit that we saw in the Japanese trial. And although we haven't formally done just a weekly versus Q3 weekly paclitaxel carboplatin study in the United States, we did do one recently that was looking at various infusion schedules in combination with bevacizumab, which is a monoclonal antibody targeting VEGF. And in that particular trial called GOG 252, we didn't see a difference with the IP, and we didn't see a difference with the dose dense. So, but that is one aspect of therapy that we have that has had some impact on management. And the reason that has had some management on impact is really the result of a different trial, GOG 262, which was taking patients that had suboptimal resections, and they were randomizing them to dose dense or every 3 weekly paclitaxel with every 3 weekly carboplatin. And in that trial, bevacizumab was allowed as a physician's choice. So in the arms of the patients who went on the study who did not get bevacizumab, there did seem to be a benefit in progression-free survival for women who received the dose-dense paclitaxel. So the story is, again, it's not so clear. It wouldn't apply directly to this patient because she actually had an R0 resection, and we don't have any direct evidence that that would be the best. So I kind of put it into that category of, yes, this is another option for therapy. And then the last one I want to mention, because I did bring it up, and that's the use of bevacizumab. So we've had several trials now. If you include 252 and 262, we've had 4 trials using bevacizumab in the frontline setting. 3 have been done in the US, 1 has been done in the European Union. And all of these trials have essentially shown that for the patients outside of the GOG 262, that there's been this impact that bevacizumab can add to the paclitaxel carboplatin backbone. In GOG 218 and ICON 7, those 2 trials were assessing just that point. We certainly can get into the details of that in another discussion, but what I would say is that both of those trials did show a benefit for progression-free survival without an overall survival advantage. So the thought is that bevacizumab would also be added to an acceptable strategy for women who have frontline therapy for women who have advanced stage ovarian cancer.